So as we discussed before in the history of abnormal psychology, there have been some therapies in the past that have been quite questionable. The one that we talked about before was triphining, which is the drilling in the skull to release the demons. And then also there was the tranquilizer chair and the circulating swing, as you can see on the bottom there. And people were placed in these and they thought that this would spawn the body into change. If they were restrained or isolated or spun or whatever it might be. And these today would be seen as cruel, but in some time they were based on very limited medical knowledge, and so we sort of have to give them kudos for at least trying something. And it did assist in developing treatments today in terms of maybe things that could affect the body on the outside as opposed to just giving drugs on the inside, which we'll talk about at the very end. Most treatments that we have today are psychotropic medications, as we had discussed before. So in terms of antipsychotic medications, in the past, for the past 2,000 years in India, they were using an herb from a snake root plant, which you see up in the right-hand corner there, to decrease hallucinations, delusions, and other positive symptoms of schizophrenia. It was also used to relieve epilepsy, and the seizures, symptoms from seizures, and also insomnia. And the reason why this herb was used is because it matched with dopamine receptors, so it could kind of inhibit the increase of dopamine so that those things could be relieved. The Japanese used the same treatment with anxiety and restlessness, and they started to develop a version of a synthetic version of the plant, which is what they often do. If they can't get the plant itself, they'll come up with its chemical composition and then have it in its own form. And this drug was called Recepin or Recepine, either one is fine. And it was used in the United States and India for high blood pressure. And then in the 1950s, the U.S. discovered that that India was using it, Recepin, for treating schizophrenia. And then along came in the 1950s also the French, who investigated a new drug, chlorpromazine, and it also decreased symptoms of schizophrenia. So these two were the first antipsychotic drugs. Chlorpromazine, or thorazine, as it's called normally, had the fewer side effects of the two, and so it really replaced Recepine for its use, and it's still used today as an antipsychotic drug. What you'll find is that chlorpromazine has some effects. It does cause dizziness, restlessness, stiffness in the arms and legs, feeling sluggish, having a stiff jaw, some increased weight, changes in blood sugar levels and heart rate function, feeling itchy or getting a rash, and so forth. There are pictures of rashes that you can see of chlorpromazine, and being sensitive to light, which is not unusual for some medications anyway. And so, people had to have their weight sort of monitored, and their ECG attached to their chest to sort of track their heart, make sure that was okay, and do some blood tests. So it's not something that is just given and used today for everyone, because it does have some side effects. Okay, so how do they work? In terms of how any kind of neuroleptic medicine or neuroleptics works, is pretty interesting. And there's a video that you can watch on how, and it's a good review for neurons and neurotransmitters and receptors. So I would click on that and watch that after I explain. But for both of these drugs, they're both reducing levels of dopamine. And the way that they're doing that is they're occupying. What they found was that, like snake root, they would occupy a dopamine receptor in the brain. And so if it sits there, that means that that's going to reduce any dopamine that's going to be released into the body. And so when we look at chlorpromazine, we are looking at an antagonist drug as opposed to something like an agonist drug. Now, these are the two things that are well confused with AP students. Remember that an agonist drug is going to create something to happen. So both like an amphetamine or a cocaine would block the reuptake of dopamine. And if we block the reuptake of it, remember as it comes out of the neuron at the terminal button, it's going to be released into the synapse. And if it's not taken up by a receptor of the postsynapse neuron, then it's going to float around in that synapse, and then eventually it will have that reuptake and put back up into the vesicle that you see there, and then be waited to use again. When we have something like cocaine, we block that reuptake, and so that has it flush out there's a lot of dopamine in the body, and then you can get some symptoms like schizophrenic symptoms by taking cocaine, because people will start to have delusions and hallucinations. With an agonist drug, like these neuroleptics, we have it blocks the symptoms of schizophrenia because it occupies that dopamine site and prevents the activation of dopamine to begin with. So remember, these neurotransmitters are natural, but if we have too little or too much of some, we have some effects on the body. Other neuroleptics also act as dopamine receptors, and because of these drugs, people really were allowed to be discharged from hospitals because they were able to function normally. So they did have a great impact on the field. Okay, in terms of drawbacks of neuroleptics, it's definitely not a cure. Patients have to continue taking the medication or those positive symptoms will return. And early medications did not affect negative symptoms of schizophrenia, like the lack of social interaction, some apathy, lack of emotion, and they actually made some of those symptoms worse. And then it produced its own symptoms as well, like dry mouth and, like we said, weight gain, constipation, sleepiness, poor concentration. So those kinds of things. And neuroleptics, they are termed neuroleptics because they suppress motor activity and emotionality. So you can see that that's something that would continue those negative symptoms of schizophrenia. Okay, and then other drawbacks also of neuroleptics are the following. It has a global effect on all those dopamine receptors. So, dopamine is used for different purposes in our body, and so it's going to eventually affect motor movement. So that's going to result in muscle tremors that normally would, just, kind of movements, rigid movements. They get a shuffle gait, so they call that the Thorazine shuffle. So they sort of like shuffle their feet along the floor, and then mask like facial expressions, because that emotionality is not there. Long-term, people can have some irreversible motor disorders. And I have a video of Peter, who is a man with TD, tardive dyskinesia. And tardive dyskinesia is what you see in the photo there of the woman. She has got a twisted, kind of painful expression, which is a grimace. And they get uncontrollable tics and chewing movements, like really big facial mouth movements of the jaw and lips and tongue. And so think about when you're watching it, it's really interesting because it has a great story of Peter and when he got schizophrenia and then taking the medication and sort of how he's dealt with that. Think about how we could use this information to reduce the stigma of mental health. And especially when you look at a picture of the woman there and think about how if you saw this woman doing this on a subway or a bus or in a restaurant, like what would you be thinking was going on, and would that make you feel uncomfortable? And if you know something about tardive dyskinesia, can you then have some more information that might be helpful? So watch the video of Peter and just to get that sense of what that is like. And he doesn't have a severe situation as she does, as you see there, but you can really see some of the just normal movements that he would do that you can tell are TD. The last one in terms of drawbacks of neuroleptics is the revolving door. So the pattern of hospitalization and then, discharged because they've got medicine, and then the patient sees the unpleasant side effects and doesn't take the medicine and then is re-hospitalized. So that revolving door of constant hospitalization. Okay, and then there's a second generation of neuroleptics, and these are going to affect dopamine as well, but also they're going to affect serotonin. You see some of the first ones there and the most recent that are used. And so in terms of advantages over the older drugs, they definitely were less likely to cause movement-related side effects. They did not globally block dopamine, so they really had to address that issue so that it was targeting some place in the brain associated with psychotic symptoms. And number two, it was more effective in treating negative symptoms, so they were getting a better result on that. And then lessening the incidence of that revolving door because they were getting less symptoms. And two of them, risperidone and olanzapine, were less likely to have relapses in general. So those two drugs in particular were used more. In terms of disadvantages, it did still have some side effects. Weight gain and cardiac problems were a part of that. Some of them developed type 2 diabetes, and especially in patients younger than 40, which was really concerning because that's not normally where we would see that. So they definitely were associated with diabetes. Larger studies showed they didn't really produce greater improvements, like really significant in the second generation of neuroleptics. So they were looking for something else. Okay, and then let's move on to anti-anxiety medications. So the best known drugs are Valium and Xanax. Benzodiazepines, so those are the best known drugs, Valium and Xanax. And for anti-anxiety, they calm the jittery feelings, relaxed muscles, promoted sleep. So these used to go by tranquilizers, and their main thing is they produce their effects by increasing levels of GABA. And we talked about GABA way back in Unit 2. It's a neurotransmitter of nerve impulses in the brain. And slow brain activity. It has to do with that energy and that activity in the brain, and it's going to use that to calm. So one of the things we talked about with our zombies in Unit 2 was we wanted to increase some GABA to make them calm down. Okay, so advantages of benzodiazepines is they reduce coordination and alertness and reaction time. So those are things that definitely they'll have more of an effect. It's intensified, however, with alcohol and drugs. So that can be a huge problem if it leads to intoxication or even death. And they can be physically addictive if taken in large quantities or over a long period of time. So then the person will then have these withdrawal symptoms. And some of them we talked about being potentially deadly withdrawal symptoms. And so that can also be an issue as well. And some of those withdrawal symptoms could be depression and panic attacks and delirium and so forth. So those are things that have to really be taken in consideration when taking these. But it's still widely prescribed. And it is one of the most effective medications that have been seen. So non-benzodiazepines is one called Buspar. And that has fewer side effects for anti-anxiety. It doesn't affect GABA, and so they're not really clear how it works, but it's thought to affect dopamine and serotonin levels. So we know that serotonin is that happy neurotransmitter, and dopamine can be that too. And so with anti-anxiety, you would think that that would help to relieve anxiety and so forth. But it also allows the patient to not be drowsy and be alert. And there's a lower risk of dependency and physical addiction, which is really helpful. And as you can see, usage can be used for short-term relief of anxiety, but also generalized anxiety disorder as well. And it can be given as a tablet a couple times a day. And again, it could cause some nausea, dizziness, headaches, sense of some excitement, nervousness, excitement in a positive way, but just feeling a little bit like that, but not in the anxiety section. So Bursar is a good advantage of that. The disadvantage is it has to be taken for 2 or 3 weeks before the symptoms increase. So if you really have an issue like generalized anxiety disorder and it's really severe, it may not be the best choice. And it doesn't treat acute anxiety effectively as much as it should. It could be used for short-term relief, but if it's just slight anxiety, they haven't seen much at a Bursar. Okay, one other controversial kind of medication that they've talked about is the use of ecstasy. We talked about MDMA in the 4th chapter, I believe, with sleep and dream and consciousness in our drugs, and that's what you see at the top there, those ones that we say don't take, the ones with the smiley faces, that is ecstasy. And so there is some growing evidence that there are a few doses of this could improve people undergoing behavioral therapy as well. So along with behavioral therapy, where you're learning strategies of trying to evaluate things that are creating the anxiety, that you then take this as well in small doses. Of course, it has some dangerous disadvantages because it can be potentially abused, and also the recreational effects can last from 3 to 6 hours. So that could be something also not pleasant for the person in taking this drug. Okay, and then also what was used and has been used quite a bit over time has been lithium. And I thought, you know, it's interesting when we look at lithium in itself, and it's a natural substance, so that's great. But just like any natural substance, you can take some vitamins can be toxic to you. And it's interesting how we can take these and it can help. And one of the things that they created was lithium soda, and 7-Up used to be a lithium soda. And I just think it's hysterical when you look at some of these advertisements. The whole family's riding the bottle, the fresh up family drink, and it gives you a good disposition and aids to good health. You know, freshen up, keep smiling. You know, this kind of happy soda, which is kind of that. And their whole one of their catch lines in their advertisements was take the ouch out of the grouch, because they had lithium in the soda at such a rate where it would create, you know, and counteract some symptoms that are related to things like bipolar and depressive symptoms. So obviously on a small level, it might make somebody who's, you know, just a little bit down, a little bit happier, which is kind of funny when you look at how they would never put that in there today. So lithium was thought of as it was used in many over-the-counter medicines before it was discovered to help with bipolar and the manic episodes that happen. So it prevents acute manic episodes over the course of a week or two, and then also helps with relapses. Some of the disadvantages of lithium, though, is it doesn't help anyone. And if you have too low, the manic symptoms will continue. And if you have too high, it can be poisonous with symptoms like vomiting, muscle weakness, reduced muscle coordination, blood levels. Definitely then have to be monitored to make sure you're getting not too much or not too little. How it works, and in terms of, again, as we go over neurons and neurotransmission, it affects glutamate, and it affects the level of this excitatory neurotransmitter. And we had talked about glutamate back in chapter 2. Lithium stabilizes the availability of glutamate, so you don't get too excited, and there isn't that excitatory neurotransmitter that's going to create a manic situation. So it prevents an abnormal high level of glutamate and a low level to alleviate manic situations and create a better mood and not have mood disturbances. It also helps in major depressive disorder, MDD. And then as we look at other drugs for bipolar, we can look at Depakote, which is an anticonvulsant medicine. And what they found with that is it helps patients who are cycling through those manic episodes, which normally, you know, sometimes people don't go through those manic episodes as we talked about, like they're not going through it every week and so forth. If they're doing it several times a year, this Depakote might help with those. And so if they're not responding to lithium, that can help as well. Okay, so let's move on to antidepressant medicines, our last section, and talk about antidepressant medicines. And Dr. Dalton talked about antidepressant medicines quite a bit because I think there was a lot of questions when he came in. And then also some of the strategies that are used for antidepressants to alleviate things like MDD. So it counters the classic symptoms of MDD, the hopelessness, guilt, suicidal thoughts, concentration, sleep, energy, appetite, and sexual desire. And so the first generation were tricyclics and MAO inhibitors, and they affected multiple neurotransmitter pathways that are around the brain that affect the MDD effects. So it increased availability of two key brain neurotransmitters that are needed to counter the depressive mood, and that's norepinephrine and serotonin, which we've talked about that. So this is an inhibitor. So it is stopping something from happening. So it is, think about it, is an agonist drug or an antagonist drug. If you said antagonist, you're right, because it inhibits and blocks the reuptake. So it's blocking the reuptake of serotonin and norepinephrine so that there's more in the body. So you see the serotonin sitting there in the picture on the right in the synapse. And so there's more in the body so the person can feel that. And it rises the levels of those or that neurotransmitter so the person does feel better. But this again, like some of the other medicines, might take up to 6 weeks before some of those symptoms are decreased. So the idea is to make sure that you monitor that person and give them some psychotherapy also to help with their mood and how they're feeling about things because they have MDD. Side effects of tricyclics and MOA inhibitors are quite interesting. The one I picked up on that I gave you some more information on is food. Weight gain, dizziness, dry mouth, sedation, being a little bit more sedated and less alert is definitely something that a lot of medicines can do. What this one's really interesting with MAO inhibitors, if you eat certain foods, it can be really dangerous and raising blood pressure. So here's a list of things that should be avoided. So they said aged cheese, so some aged cheese there, foods which can be eaten in modest amounts. So you should avoid like on these aged cheeses, but then also just not eating a lot of yogurt, ricotta cheese, commercially available pizza from large chains and so forth. So that's kind of interesting. And then also the smoked meats was mentioned. So dried, aged, fermented fish or poultry. I don't know why we want to eat that anyway, but like sardines maybe could be part of that. And then modest amounts of fresh or processed meat, fish or poultry. So with doctors' recommendations, you would want to ask something like that, or somebody would want to ask something of, is it something that I need to worry about of what foods I'm eating? Also, bean pods and banana peels, and so eating modest amounts of fruits and vegetables, which is kind of weird. It's like, oh, I thought that was supposed to help me. And then tapped and unpasteurized beer. Like anything, like if you're on a medicine, drinking alcohol is probably not a good thing, but also modest amounts of canned or bottled beer and wine and so forth is important to look at. And then looking at things like sauerkraut and like baker's yeast and things like that are in modest amounts. So it's kind of interesting to look at like even food and how it can affect these drugs. Okay, and then the second generation of antidepressants, trizodones, and something called wellbutrin or bupropion is a second generation, and wellbutrin came about a little while ago. It's been around for a while, but it gave a nice new medicine that just alleviated, especially it can alleviate anxiety. It just brings somebody up to a sort of a normal level where they don't feel elated, but they definitely feel like they're more on a normal level of than where they were. And so they can function really well, and they just feel like they have a lot of energy and are ready to kind of take on the world. So for this, it was a dopamine norepinephrine inhibitor, That did not affect serotonin neurons. So this was dealing with norepinephrine and dopamine. And they found that the second generation was really no more effective than the first, but it gave some more options for people as well. The third generation is where we really see a dramatic difference, and this is the selective serotonin reuptake inhibitors, the SSRIs. And again, we look at this idea of reuptake. They don't act on multiple neurotransmitters. They primarily go on serotonin, which you know is your happy drug or happy neurotransmitter. And this is where you get the introduction of Prozac, Zoloft, and Paxil. And Paxil, Zoloft, and Prozac have been used quite a bit. I know people have been on Zoloft and Paxil, definitely for depressant, just to get them to a level where they can function. And again, the SSRIs, again, block the reuptake. So again, they are what kind of drug? Agonist or antagonist? They would be an antagonist because they're stopping something from happening, not adding. And so they're blocking the reuptake of serotonin, which increases that in the synapse and then multiplies and magnifies that effect of it so the person's feeling better. So Prozac has always been one that is the most popular, and it's designed to decrease depressive symptoms with fewer side effects. As you looked back at Wellbutrin, it did have quite a few side effects. It produces fewer and milder side effects, but it's no more effective than any of the other tricyclics and MO inhibitors. It still has things like headaches and nervousness and difficult sleeping and loss of appetite and sexual dysfunction. And sexual dysfunction is a huge one for people because, as you know, if they're married and so forth, that can really put a strain, and mental health puts a strain on the family anyway, but that can be something to deal with as well. So you do see, you know, people with bipolar have some of those functions as well, anxiety, depression, have trouble with relationships because of sexual function or not having that desire to have sex to begin with. So there are some dramatic things on that as well. It became more popular for sure, and now it's, you know, by the early 1990s, 1 million prescriptions per month. And it was very expensive, but now there's a generic form that can be prescribed. So then Surzone and Ramirion are, along with Efflexor and Cymbalta, are 2 or 4 of the drugs that also deal with reuptake, and they have dual reuptake. So as you can see from the diagram on the right, serotonin and norepinephrine are also included in these antidepressant medicines, and you can see they're both doing that reuptake. So they're inhibiting that. So they're both working with norepinephrine and serotonin. So those are other, you know, 4 others. And Cymbalta is probably the one that you see marketed the most on television as well. Okay, and then an experimental drug, just like we talked about with ecstasy, is Special K, ketamine. We talked about this drug in section 4, and they are doing certain studies about how it can help with depressive patients. So one of the ways that you can take this drug is injection, and so a study was done and showed that 71% of severely depressed patients receiving ketamine, which wouldn't be called Special K because that is the street name for that, were intravenously given the drug, and they saw a decrease in depressive symptoms in just 1 day compared to 0% of those taking placebo. Of course, with side effects, just like with ecstasy, hallucinations, and so forth. But if you have a severely depressed patient, it's worth doing it if we're in an emergency situation, if that person is at risk for suicide, and you can't wait for medicine to kick in for 2 to 3 weeks, this would be a situation where you could use this. Again, it's an experimental drug, but it's interesting to look at if we could use it in an ER situation and reduce the suicide rates, which they've seen that happen. And those hallucinations are not going to last for more than 2 hours, but it's going to possibly save that person from doing harm to themselves. And so when it wears off, then you can administer other drugs that may help and kind of give you time to help that person. So the effects they found last no more than a week, and you wouldn't want to continue to give the person this because obviously it is a drug and can be become dependent on it. And so, but again, it's for those emergency situations to buy time. And then not only do antidepressant medicines are they used for MDD, other things, they are also used for anxiety disorders. Wellbutrin is a great drug for anxiety and just in short term. It may be given to somebody who has had a traumatic event happen and they just can't concentrate because they're just constantly worried about it. And so it can be prescribed for that too, for anxiety. SSRIs, RIs, anxiety disorders, OCD, eating disorders, and so forth. Again, all those are there, especially like eating disorders, serotonin, just making people feel better, just feeling more like the happy drug. And so that, along with psychotherapy, could definitely help somebody with eating disorders. And Wellbutrin, being with anxiety and obesity, ADHD, and smoking, the drug's called Zyban, but it's basically Wellbutrin. Okay, so when should you be prescribed and which should be prescribed to you? Definitely what we found with psychiatry is it is a trial by error, and some of you may have experienced this on yourself in terms of mental health, but also in any kind of situation where there's a medical situation that you're trying to deal with, that medicine is definitely a trial and error, that medical doses and combination of drugs may have to be administered in order to get the right combination. So they'll look at previous attempts with antidepressants, interactions with other medication they might be taking, a person's tolerance of side effects. Some drugs create horrible side effects, but then they can move on to another one. So that's a major component of trial and error. And then we know that there's genetic differences of why people respond differently. And so pharmacogenetics is the study of how genes influence a person's response. And so you can see in the diagram there, they look at a clinical trial, and the drug is administered, and then they look at good, no response, adverse, and they sort of look at why maybe that happens, and they find patterns. So in comparing effectiveness of antidepressant medicines with psychotherapy, there has been, and I think we covered this quite a bit before, but just to go over it again, the large studies have been done. Both cognitive and interpersonal therapy they found to be just as effective as antidepressant medications. And we talked about mindfulness cognitive therapy as being as effective as antidepressants. And we had talked about that several times this year. About mindfulness being a very powerful component if you do not want to take medicine. More people are treated with antidepressant medicines than psychotherapy, but I would say, like we talked about with Dr. Dalton, that he tries to start with psychotherapy first, and then if he has to use antidepressants. So I think a lot of doctors today use a combination of both if they can to help people. And then, does psychotherapy have the same effects on brain chemistry? We know it has the same effects on the brain in terms of activity when looking at MRIs, but is it brain chemistry? So they did a study, an MRI study with 27 people that had MDD, and they compared it to 25 normal subjects who were not depressed. And so the procedure in terms of what they thought should happen is that if all was going to, sort of their hypothesis was that depressed individuals should show altered brain activity following an emotional task and a cognitive task, because they found that emotional cognitive tasks were definitely things that were related to MDD, and so they were testing that. So in terms of emotional tasks, they gave them briefly a list of negative words to view that they would perceive to be personal to them. And so they found that depressed individuals saw increased activity in the amygdala. So it was not found in the control group. The control group did not see those negative words as emotional as the depressive individuals did. So the amygdala being that emotional part of our brain. In terms of cognitive tasks, they groups had the depressed individuals showed less activity in the prefrontal cortex, and the control group found more activity in the prefrontal cortex. So we know that with MDD, those individuals are showing less activity in the prefrontal cortex because they're not using their reasoning to evaluate their environment and themselves. And so that would be something a normal person would do. So it's really interesting to show like a great deal of solidification of what they were looking at with both of these, with MDD, that it really does affect those parts of the brain. So then they continued this and they looked at the 9 depressed people in that study, and they completed 14 weeks of cognitive therapy. And what they found was the brain activity of this group of 9 ended up being the same activity as the control group. So again, a reduced activity in the amygdala and an increased activity in the prefrontal cortex as the control group had been through just psychotherapy. So results found out that changes in brain activation and normalizing brain function that result can be similar, and it is similar with psychotherapy, and has similar changes like it does with medications. And these changes are not just with MDD. They found it can relate also to panic disorders and PTSD, OCD, phobias, and anxiety. So does depressants work better than placebos? Irvin Kirsch did a study. He was interested. We talked about placebos a while back, and how they do have a biological effect on the body. And so, you know, it's an appropriate part to talk about Irvin Kirsch's study. He did a meta study, or a meta-analysis, where he looked at all studies that were published and unpublished because they were subject to U.S. Food and Drug Administration approval of antidepressants. And so importantly is looking at unpublished studies because they are more likely to show no effects of these drugs, which would prove that placebos or these drugs didn't have any effect. And the result that he found with this meta-analysis was that most patients improved with either antidepressants or placebos. He did find that antidepressants worked better, especially for those people who were severely depressed, but 80% of the improvement he thought was due to placebos. So then what does that say? Like, what are we talking about then? Is drugs actually even working? Well, placebos, we know, lead to improvements in pain and management of pain, the endocrine system, cardiovascular, respiratory, and immune system. And they did some studies, and patients with Parkinson's disease experienced improved movement with the placebo. So maybe they stood taller because not the stoop posture. Maybe their arm swinging and facial expressions and flexed elbows and wrists improved. So they saw that just from taking a placebo. Another study was done where people were just holding a bottle of ibuprofen and they reported lower levels of pain. So it does have a biological hold on people. And, you know, it's not imaginary. We had discussed before with brain imaging that placebos do create a real biological change. With Parkinson's disease, patients experienced increased dopamine activation. And with the placebo, in pain patients, there's less neural activity in parts of the brain associated with pain. And in depressed patients, they experience metabolic increases in parts of the brain that respond to antidepressants. So when you look at the dopamine pathways, the serotonin pathways, all those hit different areas of the brain associated with disorders, and they've really found activation even with placebos. So is it really worth taking a real drug then, and so forth? I mean, Dr. Dalton had talked about how pharmaceutical industry really has a hold on medicine and has a lot of resources to put in advertisements and marketing. I mean, they have a lot of marketing that they put out, promotional mailings, advertisements, education and meetings, free samples, clinical trials, face-to-face sales, and they are constantly convincing doctors and patients that their medications are effective and you should spend money on them. Other researchers have really found that antidepressants are superior, though. They are not totally disputing Kirsch's findings. They definitely feel like there's a place to harness the power of placebo. But what they did was they used different statistical methods, and they found a subset of 20% patients who definitely benefited from antidepressants over placebos in all levels of depression. And what's cautious is that we need to be cautious when we learn about this, that, if you are on medication and it is being effective, it's dangerous to go off of it, because you can come into a situation where somebody harms themselves, or they have a relapse, and that's because they felt like maybe it wasn't working. So staying on that medication and talking to doctors is important. The WHO did also did a study on the effectiveness of antidepressants, and to the right there is their results. So out of 4,000 that were enrolled and so forth, there were 3,900 of those, 33 never readmitted or relapsed or dropped out, and also, so they stayed very well. For most of those patients, it really did keep them from relapsing, and was helpful to them. And then some of the last treatments for antidepressant and some other disorders, but primarily there, and also some schizophrenia, is the idea of ECT, electroconvulsive therapy. And this is in severe cases of MDD. There you can see a young kid who's just coming out of that treatment, and he looks just a little bit kind of confused and so forth, which is very normal when you come out of ECT therapy. It's electrical shock therapy. It's very quick and simple, and it's done in a hospital. And it gives brief bursts of electrical current to induce a seizure in the brain, like an epileptic seizure. And unlike what it kind of is shown in the media and had been done in the past, electrodes are placed on the temples. The patients, because they're in the hospital, they're under an anesthesiologist, and so they're given anesthesia so that they are not awake. Sometimes they're given a breathing tube and then muscle relaxers. And so they're given those shocks, and that can create some mild muscle tremors and so forth. But it's really great in treating mania, schizophrenia, and then other disorders, including MDD. So some of the side effects, as you saw from that boy there, he's kind of disoriented and confused. There could be some temporary or permanent memory loss, especially short-term events just before treatment might be lost. And you're going to need 2 to 3 treatments per week for 2 to 7 weeks, depending on the severity of the patient. You can also see some side effects to the right there: muscle pain, nausea, a brain fog, some migraines or headaches, and so forth can also be that. But for the most part, it's that brain fog and short-term memory loss that you see. And the effectiveness of it is really quite astounding. It's for severe cases of MDD, 80% of the people improved, and it was very quick. And because of that, their quality of life increased to a level like people without depression. So it can be a really life-saving procedure for someone who's extremely suicidal or severely depressed if drugs are not able to save them. And it's usually used when all the other therapies, including psychotherapy and medicine, have sort of been tried and it's not working. And if you can see there on the right, there is some percentages, even with some of these experimental things being used. If you compare ketamine, the special K, with ECT, you can see there's quite a difference in using it in terms of success rate. And for elderly, it might be even less dangerous than taking drugs for them. Some disadvantages is definitely that serious cognitive impairment that could happen, some intensive amnesia, disturbances in language and verbal abilities, but brain damage is not confirmed by research. And there's definitely some short-lived effects. People usually relapse in 4 months. And death can occur, but that's not going to be related to the shock therapy. It's usually related to, or is related to, the anesthesia that's given and the person's reaction to that. In terms of using it today, it's one of those ideas of stigma as well. Today, patients treated with long-term antidepressant medications are also followed up by ECT, and they have a great reduce in relapse using the medicine and the therapy. But movies like One Who Flew Over the Cuckoo's Nest in the 1960s and 70s definitely created this stigma and showed how cruel it was to do this to people. And so people didn't use it for a long time, and they're starting to use it more today because it's been altered in sort of how they give it. And also there's not a lot of movies that actually show it. Go ahead and click on the actual movie. There's a section of it with ECT. It's not too bad. It shows just one shock and what happens to Jack Nicholson, who is back again. He likes to be in these movies that we show. He was in the OCD movie, and you see him there in the middle, kind of with his mouth open. Him in a much younger age acting in this movie, and you can see how this movie helped to create this negative attitude towards therapy. Okay, how does it work with ECT? You can see there the difference between what you saw in the movie and this young lady here. She is not surrounded by scary people and like 10 people in a room, and she's quite calm. She's hooked up to a lot of things that are monitoring her heart rate and pulse and all that kind of stuff. And they're not really sure exactly how it works, but they think it reboots the brain by depleting and then replacing important neurotransmitters. And I have an article there, and you don't have to read it or anything, but if you're interested in looking at, challenging the stigma around shock therapy, you can take a look at that if you're interested. Okay, and then other therapies, one in particular I wanted to cover was the transcranial magnetic stimulation. So the one above it, the transcranial direct current stimulation, that's ECT, but it's just using less electricity. The one that's really new and upcoming is the magnetic stimulation, and this is the one that Dr. Dalton uses in his office currently. So you can see the apparatus there on the right, and it's going to give not an electrical current, but a magnetic, but magnetic also has its own signal. And so it stimulates certain parts of the brain with magnetic pulses of various frequencies. And with this, there's no anesthesia. It induces, there's no seizures that are induced, and it can be done in the doctor's office, in the psychologist or psychiatrist office. You do need certain licensing to be able to use some of these technologies, so that's why you see them mainly in psychiatry offices. But the way that this basically works is there's a signal from a magnetic signal that comes through the hair, the skull, all the, fluid and so forth, and it will link on to something else that's also electrical. Or has a signal, and that's going to be your neurons. So then it's going to travel along the neurons, and then is going to work to fire neurons after that. And basically what it's going to do is change the activity in a network of neurons, which could be involved in a disorder. And so sort of like that ECT, it's sort of the idea of creating some kind of change in the neurotransmission. There is a medical YouTube video you can watch. You don't have to. I just basically kind of explained it to you, but they go into more detail about how it's used. And if you're really into medicine, and you want to watch it, go for it and watch the YouTube. It's a girl from Mass General who's giving it looks like a lecture on it, that they were at a seminar or so forth, and she explains it pretty well. Okay, other therapies that they also use to create these electrical pulses are things that were implanted surgically. So the vagus nerve stimulation, you see the vagus nerve on the upper right-hand corner picture. That vagus nerve, it goes, runs through the neck and connects to the brainstem. And so the idea here is that there is that pulse generator that you see that's in the left chest wall that provides that electrical stimulation. And so forth. And so the idea that it's going to affect different parts of the brain using these electrodes. And then the deep brain stimulation, they actually put electrodes into the brain, and there's a battery-powered neurostimulator that you see there up on the upper right left-hand chest that's placed, and the wires are connected to implants to send signals to the brain. And again, these 4 therapies are the most experimental, so I would say the one that I've heard the most is the magnetic stimulation, but all are interesting things to think about with that are non-medical in terms of medicine.